Gastrointestinal Disorders by Dr. Hargraves. Here are learning outcomes. They're in one of the other PowerPoints, so you don't have to repeat them here. Acute gastroenteritis. The cause is usually viral or bacterial, and rarely it can be parasitic. What do we do in a workup for acute gastroenteritis, where a kid comes in with vomiting, diarrhea, is that we do some lab work to check electrolytes, BUN, creatinine, and particularly in kids, if they're very young, we want to pay close attention to the glucose. Then we're going to check the stool. So if there's diarrhea, we're going to do a stool culture, and they're going to look at it for white blood cells, which shows an infection, ova and parasites, so that's for parasitic infections, and then grow a culture to see what grows out. We'll also do a urinalysis just to make sure that their urine is clear. And then we're going to treat them based on their state of dehydration or hydration and correct fluid and electrolyte balances. And our real goal is to get them to taking oral oral replacement solution as soon as possible. So when we have kids who are failure to thrive or growth delay, that means they're not growing well over a period of time, or that they've dropped off their growth curve and not gained what they should be gaining for their age. It is also categorized for any child whose weight or height is less than the 5th percentile, or percent deceleration. You can see there's decreased muscle mass. This is cachexia, which is just this general kind of starvation. Hypotonia goes with this, so poor tone, weakness. You can see this kid who's probably maybe a year old, maybe a little bit older, who's got arms kind of flexed up and bent back. That's not normal positioning. You can see there's an NG tube, that's what's hanging by the ear there, and a piece of tape by the nose where it goes in. So they're clearly trying to fix starvation in this child. Some of the organic causes for failure to thrive are complications from other problems. So premature birth, where it takes babies a while to tolerate breast milk, GE reflux disease, short bowel syndrome, AIDS, or any other malabsorption problem. And then we've already talked about cardiac and how they kind of slow down in growth. Non-organic causes are the ones that are outside of the baby's body, so things like neglect or mixing formula incorrectly, those kind of problems. What do we do? We're going to measure them. We're going to plot them on the growth chart. Hopefully, we'll have an earlier growth chart on them, and we'll be able to figure out how they're doing as far as growing. Obtain prenatal and patient history, and find out what they're doing at home. How often is mom breastfeeding, or how often is the baby being fed? How are they mixing formula? Are they diluting it? Who's caring for the baby? How often is the baby eating? All of those things. And so sometimes it's just educating the caregivers. Sometimes they're diluting formula out to make it last longer, which you can't do for kids under the age of 1. And so sometimes that's all it is, and other times there's more challenges. Then we look at kids with cleft lip. It can be diagnosed prenatally or at birth. And so if it's not seen prenatally, then this baby is born and doesn't look right with a cleft lip. If it's just a cleft palate inside the mouth, then it's not as physically disrupting, but it can be a real adjustment for families. What are the causes of it? Well, there's a genetic predisposition to it. And then there's teratogens. And so teratogens are things like drugs or alcohol or some toxic something that is hitting at that period of time when the palate and the lip are supposed to be closing. It's around the time the neural tube is closing. So it's somewhere in the, I don't remember, I think it's like 4 weeks to 8 weeks gestation. So sometimes it's before this mom even knows she's pregnant, and maybe she's going out and partying and drinking, and that could contribute to this. It could be a folate deficiency, so that's why, of course, we have all women of childbearing age should be taking a multivitamin with folate in it or folic acid, or it can just be an obscure event. So what do we do for it? Well, we do surgery. We do the cleft lip, which is that little guy on the top, although you can see also he's got a palate, cleft palate back there. That's that black gap that goes back. Um, and so we repair the lip at 2 weeks, but anytime between 2 weeks and 3 months. We do this early because they can't get a good suction on the bottle or nipple, and so it's hard for them to form a seal and to drink. And I will show you a picture in a minute of how we feed them. There's this rule of tens, which means 10 weeks, which is about 2.5 months, 10 pounds, and a hemoglobin of 10, which some places use as criteria for determining it's appropriate to do surgery. The second picture next to that cleft lip, cleft palate guy is the same kid, a little bit older, looks like he's maybe 2 to 3. And you can see if you zoomed in really close, you can see that the scar is in the same place as the ridges are on most of us. And then the bottom picture is a cleft palate. So this kid doesn't have a cleft lip, and I'll tell you from the tooth on the right side, which is clearly a bigger mouth than on the left side. That's a kid who's in about first grade, kindergarten, first grade. That's around 5 to 6, where they start to get their permanent teeth. And we'll do that a little bit later. So more like 6 to 12 months. Problems associated with both of these are having orthodontic problems, as you can imagine, right? Because the jaw's not closing correctly. Speech problems, hearing, and they're at high risk for otitis media. So what are our options? Well, we use this long, soft nipple and a bottle that's squeezable. And you can see the nipple even has an indentation on it where you can put your fingers and squeeze. And so essentially we're squirting formula into the back of the child's mouth and timing it with their swallow. And this is not a good position because this is holding the child horizontally, where we really want these kids to be more upright, even more upright than most breastfeeding babies, because they have such a high risk of that fluid going into their inner ear and going up into their nose. Here's a better picture of it. And again, you can see that there's no way they can form a seal. Now, sometimes with cleft lip, if it's just a cleft lip and not a palate, a mom can try to breastfeed with some help to position the baby so that the cleft is obstructed and they can form a good seal on the nipple. If they're insufficient intake, we'll put an NG tube or a G tube, a gastrostomy tube through the abdomen if they're not eating well. Now, this is the only picture I could find of a baby with a G tube who had a cleft. This baby has a bilateral cleft palate, and then you can kind of see if you look at her, she's microcephalic. Her eyes are a little sunsetting, so they're kind of, as if the sun's setting over the horizon and you don't see the whole circle of the eye. And so she probably has some other problems also. Other things to think about with these kids is that they need to be served by a team of multidisciplinary care, somebody coordinating that care. There are psychosocial implications, like I said. This isn't the baby where you might take a picture of the baby, as a newborn and share it on social media because they don't, they just don't look as, the same as other newborn babies. Post-op challenges, we'll get into that in a minute. So it's about airway, suture line and feeding issues, and pain management. And then this is a picture of a patient having AABR, which is automated auditory brainstem response, which is the first hearing test that's given to neonates or newborns before they leave the hospital. Okay, so if we're looking at kids for post-op care, we want to look first at the suture line. So we're going to clean it. There will be orders for it, and usually we put some antibiotic ointment on it. This incision or this suture line goes from the nose, somewhere up in the nose, however deep the cleft is, all the way around the outer lip here, in the inner lip, and it can go through the gum line also. And then we're going to try and keep their hands from getting to their faces. So how do we do that in kids? We do it with elbow restraints. We put these restraints on, and now this baby can't reach up and scratch or rub the incision. And then we're going to put this baby, when we put this baby down, we're going to put them either on their back or on their side, again, so that they can't rub their face on anything. We don't want anything irritating that suture line. They can be held. This one we're seeing the feeding here happens to be up in a high chair, it looks like, or maybe an infant seat. And we feed them with a syringe. So you can see at the tip of the syringe, there's a rubbery kind of thing that we insert it into the side of the mouth and squirt formula to the back of the throat, and they swallow it down. This is how we feed them for the first, I don't even know, at least a week or so, with increasing amounts. And we usually send them home with syringe feeds that the parents will do. And the whole point is that we don't want to put the bottle in their mouth because they're going to form suction, which increases pressure on that incision. We're going to do adequate pain control and make sure they're comfortable with whatever that child needs. So whether it's narcotics or it's Tylenol, it's whatever works for them. And then this is a picture of this. I think it's the same little guy from the picture on the right. And he's had a cleft repair. And again, if you zoom in, you can see kind of the surgical line is really similar to the philtrum. And he does look like he kind of has a wider nose, but that also might just be genetic. So the nurse is caring for an infant whose cleft lip was repaired. This infant's postoperative care includes which of the following? I'm going to pause here and let you read them. Now, in thinking about what's correct, first, if I didn't mention it, it's probably not correct. So in that case, you can take postural drainage out. So that would help you throw out two of them. And then thinking about restraints, you know what kind of restraints because I just talked about it. So we're not going to do arm restraints. We're not going to do wrist restraints. We're going to do elbow restraints. That's what they're called. They're also called no-nos, but elbow restraints. So the one with elbow restraints is the best answer. Now, if we talk about GE reflux or GERD, here's just a picture of it. And basically, I know you've had this in other classes and have several patients with it probably. It's where the stomach when the stomach pushes, some of the contents go down through the pylorus into the small intestine, and some of them regurgitate up into the esophagus. Now, the esophagus isn't built to take the low pH that's in the stomach. And so it burns the tissues and causes pain. It can cause burping. It can cause a lot of problems. So what do we do for these kids? Well, the diagnostic test for kids is to put down this pH probe. And you can see it on X-ray on the right side and then in this kind of line drawing here. And the little meter thing is measuring the pH. And the tips of this, one of them is down above the stomach in the lower end of the esophagus. And the other one is up in the upper esophagus near where if the baby, to see if the baby's refluxing that far up, because then that is a risk for aspiration. And so some kids with like some chronic lung problems are really having GE reflux where it's irritating. It's going into the trachea and irritating. So what do we do for kids? Well, the first thing we do is we take them off cow's milk. So if they're on a formula that's cow milk based, then we'll change it to something else. So either a soy formula or maybe they may be doing some other kinds of milk also. Also giving small frequent feeds. So, on the theory that if the stomach isn't as full, it's not going to push back as much. And then reflux precautions. It's where we add 1 tablespoon of rice cereal to each ounce of milk or whatever we're giving, whatever formula. And then to do that and drink it through a bottle, we usually have to make a bigger hole in it. A lot of times we do a little crisscross with a scalpel, sorry, with a scalpel just make that hole big enough because now it's thicker, right? And the theory is that if it's thicker, it's not going to regurge as much up into the esophagus. And then keep them elevated after feeds. So use a car seat, a position, positioning chair, a bed, a crib with the backup and appropriate other supports so the baby doesn't, fall over. And then we can also use H2 antagonists, receptor antagonists like cimetidine and Tagamet. Now, what do we do for surgical treatment? So if those don't work and the baby's a failure to thrive, as in they're not gaining weight, then this is only for severe cases. A lot of kids will just outgrow it as they get a little more mature. But what we do with the surgery is a Nissen fundoplication. And it's where they take the top part of that stomach, and the stomach's highly muscular, right? And they just wrap it around the esophageal sphincter area at the end of the esophagus. And then when the stomach contracts to push the stuff down into the small intestine, it actually closes off the esophagus so that it can go down, so it can all go down. But again, it's not for all patients. It's just for ones with recurrent aspiration pneumonia, esophagitis, or failure to thrive. So Meckel's diverticulum, this shows up on a test. It's either the CMS test or it's the NCLEX. And it is a leftover, it's a fragment left over from the umbilical cord. And it looks like, to me, it looks kind of like a little appendix, and it's hanging off of the small intestine. And what happens is it gets inflamed, so probably something gets stuck in it, and then it causes bloody stools. So I think knowing that it causes bloody stools and knowing also apparently it's the most common congenital defect. Now, I personally have never seen a patient with this, although I would imagine that if they were, again, I spent the majority of my career in the PICU. It may be that these kids were being operated on and recovered and sent home or spend a day in a PEDS unit, which I just wasn't aware of. They do surgery on it, and it can happen. This Meckel's diverticulum can happen anytime like the appendix. It can happen anytime. Hirschsprung's disease. This is primarily pediatric because it has to do with the colon not being innervated, so not having the parasympathetic ganglion cells that tell the intestine to tell the muscles to contract. And so what happens is if you could like see through the abdomen or even watch an abdomen, you can see the peristalsis push the large intestine, and then it kind of stops in that area and it gets enlarged. These muscles get enlarged, and the intestine is enlarged. And so the signs and symptoms, so the first sign, which isn't true in every baby, but is a failure to pass meconium. So meconium is that first kind of dark stool that a newborn has, usually after birth. And if they don't pass it within 24 hours, then they start to do some additional workup. Although many kids will do this, and then you will still pass meconium and still have Hirschsprung's. It just depends on how much of the large intestine is involved. And so sometimes we'll see them we usually see them in infancy though. This is usually within the first few months of life. They'll get a distended abdomen, they'll have constipation, they might be vomiting, and they might have poor feeding. And so the surgery they have is they do a temporary colostomy. Here's the intestine. You can see on the left picture here where the intestine actually is going up above and is pushing the diaphragm up. So in general, the diaphragm should be kind of curved level with the bottom ribs. And so this intestine is pushing it up. So it's impeding the respirations. Imagine this is a baby, right? Because it's going to be on a little kid, and see how big that intestine is. So clearly it's really obstructive. So after surgery or before surgery, we're going to give IV antibiotics. We'll correct electrolyte imbalances and give some enemas, and then the kid goes off to surgery and comes back looking like this. And so there's a temporary colostomy. You can see it over on the left side there. Now, as opposed to adults, where you can see this is pretty much at the level of the umbilicus, as opposed to adults where you try and place a colostomy so it's under their clothes, usually under the pants. In babies, we want it where it's most convenient for caregivers. So it's usually above the diaper, well, it's always above the diaper, and usually then we put the bag on so it points over to the side so it's easy to empty. This is the first surgery. So what I need you to remember is that this baby's going to go home with a temporary colostomy and stoma care for a few months, and then they're going to come back and they're going to have a pull through. And the pull through is where they connect these two ends. So they've taken out the aganglionic part, and so they've got the part that goes to the rectum, and they've got the part before that, and they're going to put them together. And it has two names. It's called a pull through or an ostomy takedown. So then we have inflammatory bowel disease, and I'm sure you're familiar with these two also, Crohn's disease and ulcerative colitis. I like the visual on this one because it shows me the healthy bowel and what it's supposed to look like. And then when we look at Crohn's, what is the disease entity? Well, it's muscle hypertrophy in the colon and fat wrapping around the outside. And then it also causes fissures. And then it has this cobblestone appearance, right? So if they're doing a colonoscopy, they'd be able to see this. And the fissures will bleed. So there's, can bleed and can also perforate outside of the intestine. And then in ulcerative colitis, you can see it's not affecting the muscle, or it's not affecting, there's no fat wrapping around it, but there's ulceration in the mucosa. And so it's a significantly bloody one. So our two types are, the differences between the two types are that the ulcerative colitis is in the colon, almost exclusively in the colon, although sometimes there's gastritis with it. And the Crohn's disease goes through the entire GI tract, all the way from the mouth down to the anus. And so it can inflame anywhere in that whole area. You can see there's uniform progression with ulcerative colitis. So anywhere they look in the colon is going to look pretty much the same. And in Crohn's disease, it's uneven spread throughout the entire bowel system. So it might be part of the small intestine and part of the large intestine, and maybe something in the stomach or something. What are they doing? What are their symptoms? So ulcerative colitis, again, bloody diarrhea is the classic sign, abdominal pain, weight loss, and ulceration and bleeding. And then for Crohn's disease, it's abdominal pain, weight loss, diarrhea, and they're at risk for perforation of the colon and toxic megacolon. And then I don't really care about the extraintestinal symptoms. So which one benefits most from surgery? Well, that would be Crohn's disease. That would be ulcerative colitis, because that's the only one that you can remove it all and a person can live. Now, our colons, their primary job is to reabsorb water. So when someone with ulcerative colitis has an ileostomy, which means they've removed the entire colon, then they need to take additional fluids, but eventually the body adapts and absorbs enough fluids. In Crohn's disease, although some patients will have a colostomy or have part of it removed, it isn't the standard treatment because it doesn't really get rid of the disease. And then if we look at celiac disease, I'm sure you know somebody who's not eating gluten because they don't tolerate it well. This is the actual disease. It's also called gluten-induced enteropathy or celiac sprue. That's the name I remember from when I went to nursing school. And then it has 4 characteristics, and they're steatorrhea, which is fatty stools, general malnutrition, abdominal distension, and secondary vitamin deficiencies. So if somebody says, I'm on this gluten diet and they're overweight to start with, they probably don't truly have celiac disease. Why do they improve and feel better and maybe even lose weight? Because the gluten products are in a lot of the processed food that we eat. So not just wheat, not just bread that's based on wheat products, but crackers and cookies and a lot of the processed food. And so by eliminating that processed food from their diets, they're probably seeing some improvements in health. You can look at the villi here in the intestine and see the surface area that is supposed to be there. That's the one on the left. So it's supposed to have this huge surface area, and instead that doesn't work. And it retracts down, and so the whole, if you think about it, and it's based on gluten, um, and and the whole thing just becomes this nice smooth absorbent area, and so of course they're going to be thinner. Of course their stool is going to go through and be fatty because they cannot absorb what they need to absorb. Um, and what There is a test for it. It is a test that measures whether they have antibodies to gluten. And so, in order for the test to be accurate, the person has to actually be eating gluten products at that time because that's what would trigger the antibodies. There's another, I guess they're both antibodies. So it's an immune reaction, which then puts it into the autoimmune disorders, right? Which also, I know ulcerative colitis is also considered autoimmune. And then short bowel syndrome. This is almost always in premature babies. And it's the typical cause is necrotizing enterocolitis, which I don't think you need to know, but it's where there's an infection in the small intestine. It's again mostly premature babies. They get vomiting with bile in it, so kind of green vomiting. And if it's treated with antibiotics, it's a bacterial infection. So if it's treated with antibiotics quickly enough, surgery can be not necessary. Although it's more common that the infection is set up and it gets to, I mean, necrotizing, right? It's going to be killing the intestine. And so they take them to surgery and they resect that part of the small intestine. Well, again, remember the small intestine, that's where all the nutrients are absorbed. So this creates a malabsorption disorder for these patients. So then after resection, of course, there's going to be a smaller amount of intestine to absorb nutrients. So what do we do for this? Well, first, we're going to give them the best, strongest, formula that they can tolerate to maximize the nutrients. And then what happens and then they'll need ostomy care because this also goes to an ostomy. I don't know that it's long term. I think it's pretty sure it's short term, and home care. And then if there are other problems and they're not getting enough nutrients through the GI tract, then they end up being on TPN for life. And the challenge with TPN for life, or they get a small bowel transplant. But TPN for life, the problem with that is there are only so many places in the body. You can start a central line that will go into the heart that will give, because that's where it has to go in order to give a high glucose. So, and it's usually any glucose over 15% in kids needs to be centrally delivered. Okay. What are our goals for short bowel syndrome? Is to preserve as much of the bowel as possible during surgery, to maintain optimal nutritional status, growth, and development while intestinal adaptation occurs, right? So the body's going to try and adapt. It's going to go, whoa, we're still not getting enough nutrients, and it's going to do better, right? Stimulate intestinal adaptation with enteral feeding. So as you know, in many patients now, there was evidence-based practice from probably about 15, 20 years ago, was even if we just do trickle feeds, maybe 5 mLs in an adult, maybe even, 1 ml in a premature baby, 1 ml an hour on a syringe pump, it reduces post-op complications and helps the GI tract recover quicker. So giving them, so it's a stimulation, but it's not like saying, let's start feeding so we can expect them to get all their nutrients from it. It's more like gut stimulation. And then minimizing complications. And then these are TPN and lipids. The big bag at the top left, I've never actually seen. I'm guessing that's an adult size bag. The two on the right, the TPN bag that's 500 mLs, and the lipids that's either 25 to 200, or sorry, 50 to 250 mLs or more, the pediatric size. And then our goal would be enteral feeding or long-term maintenance, and hopefully they won't be dependent on TPN and lipids.